All right, guys, it's 9 o'clock. We'll get started since we got folks online. So for those of you online, we are live in Huntsville today. Thank you, Huntsville Fire and Rescue and the training center. It's a great facility. This thing is nice and huge, so super nice. Thank you for having me out this way. We got a good day today. We're going to do some lectures on resuscitation. And then Dr. Gulledge is going to talk about some cardiogenic shock and some LVADs for us. We got lunch coming at 11. If you're in the area, come out and eat with us. And then we're going to do some scenario-based training, some BLS airways, some advanced airway. I think some people call it the salad training or the vomit head mannequin, and do some cardiac arrest training as well. So good stuff today. So disclosures, as you know, we do give, in addition to the EMS Con Ed credit we can give nursing and physician CME. So if you're in need of that, or if you're in a hospital setting, one of the nurses there, please share with your colleagues and your docs. You can get free CME from us as well. So nothing to disclose. We are sponsored by the Fire College. And then UAB's Emergency Medicine Residency Program is also a supporter of us as well. The goal for today is not to let you sleep. I know where's Dr. You like cats, so I got that for you. There you go, yeah. And this is my inappropriate sarcasm, at least the first one, maybe more. But, you know, if you've heard me say things, I think that the role that EMS provides or plays in our community is physician level care. The problem is you don't have the access to the med school or the training in the hospital. So one of the goals of the EMS Challenge program is to get our docs out there involved with you to make sure you're on the right page and that you're able and comfortable taking care of some of these sick patients that you take care of. So just what the EMS Challenge is, I won't bore you with that. Some upcoming events, we'll be at FDIC. We got a couple of lectures there, and at the EMS Summit there. Then CCTMC is in Orange Beach this year in April. It's a great national critical care conference. It's in our own backyard. For you flight programs, the folks that want to do critical care paramedicine or the nurses, a great way to get introduced to that, and it's in Orange Beach. You can't beat it. We're in Bessemer at the new UAB Midwest, sponsored by McAdory Fire on April 8th. And then we're out in Albertville, which is near Gunnersville, again, end of April. So a lot of places all over the area. Come out and train with us. So altered mental status. So lots of causes of that. I'm going to kind of cover a couple of cases with this, but it could be anything from drugs, hypoxia, trauma can make you alter mental status. Sarcasm, malingering can do it. For the older groups, folks in the crowd, the Clinton Foundation can make you altered as well. And then obviously glucose is a big one in the Deep South. Always check glucose. And then alcohol. Alcohol is a big cause of altered mental status. How many Alabama fans we got here? Exactly. You understand what I'm talking about with alcohol and altered mental status, right? Yeah, cool. All right, so our first case, the first case is always the more expensive case, right? So patient moans to painful stimulus. They got contusions, abrasions of their scalp. Belly's a little bit distended. His girlfriend says he's been drinking. So we got some vitals of a heart rate of 133. Blood pressure is 90/60. Respirations in the 20s. Satin 95%. The glucose of 168. What are your concerns or thoughts on that one so far? Is the dog okay? That's what you're thinking? Yes, I understand. The dog's name is Earl. The guy's name I don't care about, right? But the dog is Earl. The dog is fine. So heart rate's way too fast, right? So heart rate's a little bit too fast. Blood pressure a little bit soft. Breathing 20 times a minute. Who here, when you count respirations, actually counts for a whole minute? Raise your hand. Anybody do that? I do not. I don't have the patience for that. So how long do you count for your respirations, or you just make up a number? Who just makes up a number for your respiratory rate? Thank you very much. Honesty from the physicians, right? It's like, yeah, they're breathing and it looks okay-ish, right? So yeah. So work of breathing is always more important than rate of breathing. When I think about rate of breathing, if I'm going to actually count numbers, I'm going to watch them breathe for 6 seconds and multiply times 10. And I do that because I can multiply times 10, right? And that gives me a rough estimation that they're breathing okay. If they don't breathe in that first 6 seconds, that makes me uncomfortable. The rate is less than 10, right? If they're breathing 3 times in that first 6 seconds, that is too fast. That makes me uncomfortable because that's 30, right? It's a screening tool of my respiratory rate. Sats are reasonable. Glucose of 168, who likes that number? Yes, yes, that is almost hypoglycemic in the deep south, right? But that is okay. Sweet. So are they drunk? Are they sick or not sick? I would argue they were sick because they're unresponsive. All right. So what are we going to do with these folks? We're going to start exposing them, roll them over, and we start making a differential diagnosis. And that's a physician term. But in short, EMS does the same thing. You start running through your mind, what could be going on? Are they drunk? Are there bullet holes in the patient? Do I see obvious signs of trauma? Are there fentanyl patches? What's going on with them, right? So I've been pushing this for the past year or so. I like saying the ABCs, and that's great. But remember, the goal of this is we want to make sure that we're assessing and managing. Are they oxygenating well? Because we can fix those problems in most people. What is the ventilation status? Are they moving air in and out? We can address that if we need to. Vascular system, is their heart rate and blood pressure reasonable? And if not, how do we correct that? And then neurological salvage. And I say salvage because if we have an underlying head injury, we can't fix the part of the brain that's jacked up, but we can prevent secondary brain injury, and we do that by a couple of ways, right? So let's talk about alcohol, and we'll go back to the case with the dog named Earl. So alcohol, I won't ask here who drinks alcohol. I definitely won't ask who drank this morning because I'm looking at some people that look like they're having way too much. Yeah, sure. Yeah. So alcohol has a lot of effects on the body, things we don't think about. So it can cause some amnesia, all right? And it makes you forget things that you do. It makes you kind of decrease your inhibitions. It relaxes the pharynx, so you have more risk of aspiration. You also get obstructive sleep apnea from it, and you can swallow things that you probably shouldn't swallow, like goldfish and things of that nature, right? Long-term alcohol use can cause some underlying encephalopathy, cause some cerebral atrophy, alcohol dementia syndrome. You can have a lot of problems with long-term alcohol use. You get some neurological signs such as nystagmus. Any law enforcement in here? Nobody's going to raise their hand, obviously, so thank you. Good. But you can get some nystagmus as well. And then long-term effects on the body, we think that alcohol makes you strong and robust, and actually what it does is it breaks down muscle proteins and makes you become more unhealthy. So a lot of issues with that. Psychiatric issues are more pronounced with alcohol and drug use. You see folks who have underlying psychiatric or mental illness who use alcohol and drugs, and they become unstable or have other issues with that. Malignancy, you have an increased risk of oral cancers, esophageal cancers, and some other cancers as well. There is some medical benefits to alcohol use. You can increase your HDLs. It makes your blood thin out a little bit. So for a cardiovascular protective risk, a little bit of alcohol is good for you there. But the question then comes, is the risk worth the benefit? Other issues with alcohol, you get some transient hypoglycemia, you get some liver issues, you can get alcoholic ketoacidosis where you drink all your protein, your energy that you need, and you get muscle breakdown. You get some thyroid issues. We already talked about thinning blood. Alcohol causes a lot of gastritis. You can get ulcers, GI bleeding. You can cause pancreatitis, hepatitis, cirrhosis. All things are bad. From a cardiac standpoint, alcohol can act as actually an irritant to the heart. You can cause what's called holiday heart. Again, Bama fans, where are y'all over there? Very dangerous. You can get you some AFib over the holidays if you drink too much. You get some decreased cardiac contractility. You get prone to having long-term arrhythmias. You can get some cardiomyopathy. And remember that alcohol is a CNS depressant, so it pushes everything down, right? So it makes your blood pressure get lower, your heart rate get lower, and the body's response to that is to build everything back up and push it back up. So with withdrawal from alcohol, you can see some big issues. The other thing is, I'm not going to ask you here who smokes, but I will say in a kind of an internal survey, who smokes more when they drink than when they don't drink, right? So tobacco use, other drugs go along with alcohol that causes issues with that. And there are some reproductive issues with alcohol as well. And again, I'm looking at the Alabama people just to make sure you understand these things. And then we'll move along. Other issues with alcohol is it actually messes up the liver. It causes cirrhosis. It causes hardening of the liver. Remember, the liver gets its blood supply from two sources, the aorta and also the portal system. So anything you eat or drink, as the body digests that, it goes to the liver. So alcohol is really a toxic substance for the liver as well. So the liver tries to filter that out, but as the more you consume the alcohol, the parts of the liver that does the filtering start to die off, and you get a backflow, you get portal hypertension, you get where the liver does not work as well, and that causes a lot of the issues that we see with the alcohol there. Another big risk factor for cirrhosis in the Deep South is diabetes because of elevated glucose and triglycerides. You get a fatty liver. And again, all that really does from an EMS or ER perspective is it makes the liver not function, so you get all the bad side effects that we talked about from the alcohol there, and you get some portal hypertension. So liver does lots of things, helps with immunity, helps with blood coagulation, with metabolism, stores fats and proteins. A lot of issues there. All right. Anybody asleep yet? No. Good. Good. That cat, once again, is for you. All right. All right. So let's go back to Earl. So sats are now in the 85% range. Heart rate's tacky. Blood pressure a little bit soft. So what are the things we're going to do for this guy first? All right. I know we pet the dog. Somebody's assigned to take care of the dog, give him some water, make sure he's good. Dog is fine. So what are we going to do for this guy? Roll him over, clear his airway. Does he need some oxygen? Yes. Remember, my thoughts on O2, regardless of what American Heart says, is that the only people that have a true contraindication to oxygen are people that are on fire. Everyone else can have oxygen, and you can titrate to effect once you figure out what's going on with those people, right? So we're going to roll this guy over, start making a differential diagnosis. I'm going to open his airway. If there's blood or vomit in the airway, I'm going to grab my suction and use that. Maybe I pull his shirt up and wipe out his mouth with that as well. I'm applying some O2. We've already got a glucose on this guy, so that's fantastic. And now, because we think he is sick, because he's unresponsive to us, we're going to expose him, start looking for life threats, right? Start looking for fentanyl patches, looking for holes, abrasions, contusions. We already see he's got some trauma to his forehead, right? So what else could be going on with this guy besides being drunk? He could have a head injury, right? His wife could have hit him across the head with something because he came home drunk, right? Maybe he was trying to kill himself. He took some other medications. You check his pockets, right? Maybe there's some underlying health problems, right? He's tachycardic and hypotensive. Maybe he's been laying there for the past day and a half, and now he's in a rhabdo, and he's got a kidney injury, and he's hyperkalemic. So a lot of things you've been thinking about, right? That's what you guys are thinking about. Most of you guys in the fire service, right? I got it. I'm not stupid. So we're going to assess and manage oxygen, ventilation, vascular control. For the EMT level trainers in here, these guys get O2, open the airway, suction the airway. We got our glucose. We're going to expose him, look for life threats, and we're in the foam. I need ALS and transport for this guy now. For those that are at the EMT level or above, this guy probably needs IV access and some IV fluids for rehydration, right? Cool. Talked about his glucose. Then when you think about people that drink, we talked about they're more prone to bleeding. They bleed easier. They're almost naturally anticoagulated. So they're at a higher risk for having head injuries. The other thing with alcohol is, remember, alcohol causes cerebral atrophy. So you got these bridging veins that run between the skull and the dura. As the brain shrinks, you get extra space there. So even small falls, injuries of that nature can cause subdurals. The cool thing is, most of the folks that have alcohol or drug dependence are older age and have cerebral atrophy. If they get some bleeding in there, they got more space to bleed before things bad happen. The bad news is they're high risk for bleeding, right? So it's always dangerous. So this guy could have a subdural, right? Subdural hematoma, and that's below that organic saran wrap covering of the brain. If you're doing a CT scan, I know for the hospital folks, you can look at this. This white stuff on the CT head is blood or fluid. We assume it's blood, and that's bad. And that is a subdural. This could be nice and rough looking because it's under the dura. All right. One of the questions that you want to ask the patients, if they can talk to you, or not them, you can ask the family, what drug question do we want to ask these people? What history question? Anticoagulation, right? So if I got an alcoholic that's intoxicated and hits his head, and he's also on Coumadin or Xarelto, that kind of doubles the risk, right? At least in my mind. So the different types of brain injuries, so you can have a subdural, you can have an epidural, that's more common. Someone has a blunt injury, lateral side of the skull, they go unresponsive, they wake up and do fine, then 45 minutes later they go completely obtunded again. Subdurals are usually more subtle, takes a little bit longer for those things to cause the issue, unless you're actually intoxicated, right? And then you can have hemorrhagic strokes or intracerebral hematomas, bleeds as well. Again, the goal of these three things is to prevent worsening damage from these guys, right? This is a CT scan of an epidural. If you ever see one of these clinically, you've already missed it. They should already be moving toward the OR. You should have already talked to neurosurgery. These guys should have been in the OR 10 minutes ago. But you can tell it's nice and smooth, and it's above that dura, and that's why the CT scan looks so pretty in relation to the one that's a little bit rough. So goals of care, again, assess and manage. Old school was ABCs, but I say oxygen, ventilation, vascular system, and save the brain. So what is this? Jane's addiction. I'm not sure what that joke was supposed to be. Let's see. Oh, three things. What three things, there we go, do we do? Three things that we do to prevent secondary brain injury. What three things can we do in the EMS world or the ER world to prevent secondary brain injury? Yeah, prevent hypoxia, right? And that's one of the things we talk about, assess and manage oxygen and ventilation. We know hypoxia is bad. Yes, too much oxygen for days is bad. For little kids, for folks with strokes and heart attacks. But in the short term, hypoxia is bad. People have bad outcomes. Look at the EPIC trial. So prevent hypoxia. Open the airway, nasal cannula, high flow. If you don't like my thoughts on that, put a non-rebreather on them. Put a nasal trumpet in, oxygen, okay? Cool. What's two other things? We got to prevent hypoxia. What are the other two things? No, not, yes. Glucose is super important. You're correct. We should get a glucose, but that's not one of the three things I'm thinking of here. Yeah, prevent hypotension. So hypotension is bad. The brain's got to have blood pressure, right, to perfuse the brain. So this guy's got a heart rate of 130 and a blood pressure of 90. That's too low. So at the advanced EMT or higher level, they should be doing IV access and doing what? IV fluids, increasing that. If you're a critical care, maybe you're also thinking in the back of your brain, all right, I think this guy's got a head injury. He's got signs of head trauma. He's unresponsive. His glucose is great. He's an alcoholic. I know he's got a risk of bleeding. I'm going to open his airway, check a glucose, IV fluids. And if that doesn't do it, maybe I'm doing some push dose epi, all right, or doing something else. This guy's got a heart rate of 130. So what's maybe a better push dose epi, pressor for this guy instead of epi? What now? Neo's great, or if you got some norepi. And even non-critical care units in our state carry norepi now, so that's a reasonable thought. Hey, maybe I'm going to hang a little bit of norepi for a couple of minutes. Now, if you get the blood pressure up and it goes to 160 over 90, hey, great, roll tide, crank it back down, right? But you want to get the blood pressure up a little bit. So prevent hypoxia, prevent hypotension, and what's the third thing? Watch my fingers, I'll count. Sir? Yeah. You don't want to blow off that CO2, right? Because if you blow off that CO2, you get vasoconstriction in the brain. So the part of the brain that's dead is still going to be dead. The part of the brain that's kind of dying is now going to die because you've constricted off all that collateral circulation. So you don't want them to breathe fast, okay? That's hard to manage unless you're critical care. If the guy's breathing 34 times a minute, you can't pinch his mouth and hold his nose closed, right? Right? That pinch his mouth, or vice versa. That sounded weird, didn't it? Yeah, it's like a bad movie. So you can't do that. But if you're critical care, that's somebody that you can take their airway, right, and control the ventilation and watch that end-tidal CO2 and keep it 35 or better so they don't get that low end-tidal CO2 and get vasoconstriction. So those three things are pretty important when we talk about head injury management, right? Cool. Wait. All right, next case. And you know, as the night progresses, the cases change and the type of refreshments right? It gets worse. All right, so this is a young 49-year-old fella. What? Oh, okay. You know him? I can change the picture real quick if you know him. Okay. Worsening confusion. He's got some nausea, some vomiting. He's had some black diarrhea and some frequent falls. Heart rate's in the 90s. Blood pressure is 130 over 60. He's breathing about 18 times a minute. His sats are 96%. His glucose is 89. So what do you think about this guy? Thoughts, plans? Is he sick or not sick? Somebody said sick. Who says not sick? Nobody's going to say not sick, are you? Because I'm talking. I got it. Yeah, I think his vital signs are pretty reasonable, all right? But he's confused, so that makes you think there's something bad going on with his brain, right? So something's causing that. Is it an injury? Is it metabolic? Is it something else? Maybe he's always that way, all right? But if he's not your family, you don't know that. You got to assume that something ain't right. So what kind of differential diagnosis or what kind of thoughts could be going on with this guy? Wife says he's been drinking since Bill Clinton got impeached. Yeah, yeah, there you go. I said Bill Clinton, now we're all going to get in trouble, aren't we? Yeah. Yeah, so you start thinking about, again, alcohol-related issues. So now maybe he's got alcoholic hepatic encephalopathy or something. That's a big fancy word, right? But what's going on is your liver is destroyed by alcohol. You can't clear proteins. Remember, anything that you eat, when it's digested, the blood absorbed from the colon, the gut, it goes back to the liver. If there's proteins in there, the liver breaks that protein down and makes it to a water-soluble component. If the liver's not working, you can't make it water-soluble, you can't pee it off, so you get a buildup of ammonia in the blood. Ammonia actually crosses that fancy blood-brain barrier, and you get confused. So you see folks who have liver disease, don't smile at me, liver disease, alcoholic cirrhosis, and they will get confused. Textbooks talk about asterisks where their hands kind of flap and waved. How many times have you seen that? Like that, yeah. Yeah, a couple of times, yeah. Just the other day, yeah. I don't mean at the house. Okay, yeah, right. So, yeah, so that is classic. But in reality, what you really see is you see a buildup of ammonia, and these guys just get confused. They kind of ramble on like I'm doing right now, talk kind of strange. All right, and that's because that ammonia crosses that blood-brain barrier, and it causes confusion for those guys, right? Cool. The way we treat that in the hospital is we give them something called lactulose, and that helps clear that ammonia from them. But this is a diagnosis of exclusion. What other things should we be thinking about in this young 49-year-old that's confused, right? A little bit vitals off, glucose normal. We know he's an alcoholic, he drinks. We always got to be thinking about those head injuries, right? Because remember, we've got that cerebral atrophy. They're always high risk for having head injuries. So yes, I can be thinking just like you, yeah, this guy's probably got a GI bleed. He's got blood in his gut. He's absorbing that blood. His body thinks that's food and protein, so he's got hepatic encephalopathy. But in reality, we also got to think, did he fall 2 days ago? Now I have a subdural. Think about those issues as well. So my treatment for that guy is still going to be make sure he's talking to me, make sure his airway's clear, a little bit of O2 for this folks. I'm going to do IV access where I got a glucose. I'm going to start some fluids on him. I'm going to do a good assessment to see does he have any kind of head injury on that guy as well. But this is usually a diagnosis of exclusion. I would argue that most of the patients that I see in the hospital that are cirrhotics, that have an elevated ammonia level and they're confused, I still wimp out and I get a CAT scan on them because remember, if they have enough liver disease to make them encephalopathic, confused, right? They probably have enough liver disease to make their blood thin, and they're like anticoagulation, high risk for head bleeds. Cool. And then you mentioned maybe he's got a GI bleed, right? So with liver disease, you get that portal hypertension, right? So you get a backflow of blood on all the vessels in the gut, and you get esophageal varices. Classic textbook picture presentation for that is bright red vomiting come out the mouth hole, right? In reality, those things can leak and dribble a little bit, and they can digest that blood. The body thinks of that blood as like a nice steak dinner, makes those proteins. They can't clear it. They get confused. And then you get black digested blood coming out the backside. So good call on that. So these are high-risk patients. Long-term alcohol use, patients with cirrhosis can go from talking to you looking reasonable to near death in a matter of minutes. Have you ever seen somebody with esophageal varices before, a patient that had active bleeding? Sick or not sick? Sick, yeah, super sick. Yeah, a lot of these folks die. So again, the reason we're getting that elevated ammonia in folks with GI bleeds is because the body thinks any blood is food, right? So even your own blood, it starts digesting it and making those proteins. You can't clear them. You get hepatic encephalopathy. You get confused. And then, oh, by the way, I've been having some black diarrhea. And again, it's all due to the fact the liver is scarred up, cirrhosed from liver disease. And if they have underlying psychiatric issues or hepatitis, that can even make that worse, right? Portal hypertension, again, the liver gets hard. The blood supply that comes from the aorta goes great through the liver. The blood supply that comes back from the colon, the gut, the stomach gets backed up, and you get these huge vessels, right? So this is another case. This was a call for a cardiac arrest at a local surgical center. There was a patient there that had a history of liver disease. They were being endoscoped for banding of a esophageal varices. And they had a respiratory event during this procedure, then a GI bleed, then went into cardiac arrest, right? So goals of care for this patient in the GI center, just like in the field: assess and manage oxygen ventilation, vascular control, and save the brain. We talked about the reason for the portal hypertension and what it causes. And what they were trying to do is go in. This is a scope picture here on your left of the vessels. So that's the esophagus, and those are vessels. Normally we think that the veins are low flow, low volume, but with that portal hypertension, these things get really big. And if those things pop, they just start pouring blood. Anybody seen a varicose vein bleed before? Bleed like crazy. And you stop that by putting your finger on it or dressing on it. You can't do that if there's bleeding in the esophagus, right? So these guys are high risk for hemorrhagic shock, bleeding out pretty quick. What we try to do is we try to go in with a scope and either band or burn these vessels down so they can't bleed before they bleed. The problem is sometimes when you go in with a scope and try to band them, what happens? We pop them open, right? So this guy was at a surgery center, scoping him. They pop some of these vessels. He starts vomiting blood. He gets more hypotensive, goes in cardiac arrest from blood loss. And then because his mouth is full of blood and vomit, they can't get an airway for a few minutes. So high-risk patient. Super crazy. So this guy got a short course of CPR. When the EMS, the fire agency shows up, anesthesia just got him intubated. Blood pressure running about 60. He's got bright red blood coming out the mouth hole, just still pouring out of the mouth hole. I like that word, mouth hole, right? They're bagging it 10 times a minute. His sats are 99% now. His end title's 22, heart rate's 138. What should we do for him as an EMS provider? Showing up at a surgical center where you have an anesthesiologist and a GI doctor, 4 nurses, 2 custodians, and a poodle there to help you. What now? Yeah, leave the surgical center. Very good. I like that. Again, diesel fuel makes a big friend, right? Very good. So airways confirmed. We got him being bagged. He's still hypoxic. Blood pressure is low. What medicines, what fluids are we going to give him? Yeah, he needs blood, right? So if your agency carries blood, he gets blood right now. If you're carrying component therapy, packed cells, and plasma, he gets plasma, then blood. I'll probably go that route. All right. If you're carrying whole blood, that's better. Whole blood, you can squirt a unit of blood to him in less than 5 minutes. What else can he get? Somebody said TXA. Who would give TXA to this guy? Nobody's going to answer over there. I can't get my doctor friends to answer. He's dying. What's the risk? Yeah. So the study that looked at GI bleeds, I'm not a big fan of them because they were given 1 gram of TXA push and then a gram over 8 hours. And they were doing it, 12, 20 hours after the insult. This guy just got his varice perfed by us, and now it's spraying bright red blood. My rule of thought is they get TXA. So if you have bright red blood coming out of your mouth hole or the back end, I call that an acute hemorrhage, right? And if that starts within 3 hours of you getting there, they get TXA. Limited risk, okay, and possible benefit. They get 2 grams IV push. All right, so blood, TXA. Why is his end tidal CO2 low? He's being bagged at 10 times a minute. So did you slow his rate down? Why is his end tidal CO2 low? What now? It could be. Yeah, SATs are 99%. I think if he aspirated, it'd probably be hard to oxygenate too. But what's another reason that end tidal CO2 was low? What do you see in trauma patients that are low blood pressure? It's not perfusing. So that's a perfusion issue. So I would say, yeah, I don't think that's a ventilation issue. That's probably a poor perfusion. He needs the blood and the fluids, and that affects your end tidal CO2. Cool. Good thoughts. So assess and manage oxygen, ventilation, work your way through that. Vascular system, I would say he is sick and dying. Blood pressure is 60, heart rate of 130. So yeah, he's getting TXA, he's getting blood. I would also give him something else. What else could you give him to kind of bridge the gap till the blood gets in there? some push dose pressors, right? So maybe some Neo, some LVAD, a NorEpi. Sorry, I can't say LVAD. I apologize. NorEpi. I'd even do some push dose epi on this guy as well, even though his heart rate's in the 130s. Acute treatment for these guys with variceal bleeds is airway management, so they don't aspirate. Major bleeding, so like you do in hemorrhage, so blood control. Some people do NG tubes in these folks, and that's fine. But remember, you may pop one of those varices or hit that. They are not contraindicated in varices. Just be advised. Classic medical teaching is put an OG tube, NG tube in to see how much they're bleeding from an ER perspective or an EMS perspective. I don't care. I know they're bleeding. I'm a volume resuscitate them until they get better. Okay. In the hospital, we give something called octreotide. In theory, that kind of constricts those vessels. Sometimes we do PPIs, which are like proton pump inhibitors to kind of decrease bleeding or acid production in the gut. TXA, I'm a TXA guy. I say yes. Some folks say no. Either way is fine. Talk to your medical director, see what you want to do. I can tell you if I'm reviewing a chart for legal and I got somebody that's dying of hemorrhagic shock, even if it's at or around that 3-hour mark, and you give TXA, I'm going to say roll tide, perfect. No harm, no foul. And then we can do something called a Blakemore tube. Anybody here put one of these in? It's like 1973 medicine. It's great. You basically have this long balloon that's got two pieces on it. It looks like one of those puppets not puppets, those balloon animals you make in the park, right? So you gently place this in their mouth hole, or you shove it down, and then you inflate the distal piece, which is this big balloon here, the big circuit of the balloon, and then you gentle pressure, you snatch it back, and that holds pressure against that esophageal gastric juncture, and then you inflate the hot dog portion part of it, and that puts pressure on those esophageal varices. If you're doing this, it is in game. This is very not done often. It is a Hail Mary, but it is there and it can be done. I've probably seen it done 3 or 4 times my whole career. For the ICU people out there, I know most of the ICUs carry a football helmet and they use it to secure the Blakemore on there. In reality, people just use that as a popcorn bowl on holodays. If I'll secure this, I've secured it to an IV pole is what I've done before, or I've had the med student sit there and hold it and hold the arm up, or get an orthopedist. They got big arms, or maybe a fireman. They got big arms too, right? They can just hold that up there. I'm gonna get in trouble, aren't I? All right, moving on. In game to fix these folks, the easiest thing to do is do a TIPS procedure. This can be done even at some of the community hospitals where they go in and they take a tube and they put a tube from the portal system back up to that vena cava, and it basically deflates all those varices. And that stops the bleeding process. So the case we're talking about was a young male in the Birmingham area at a surgical center. They scoped the guy. They had no blood products available. He had a respiratory arrest and had acute GI bleed. They happened to call Birmingham Fire and Rescue. They show up. Oh, by the way, we carry blood. So they're hanging blood on this guy. Anesthesia got him intubated. We did some push dose epi for this guy. Short course of CPR. We get him to the main ship. And they're able to go to the OR and do a TIPS. And this guy actually walked out alive a few weeks later. So high-risk patients, you got to think about these things. In-game is a good resource to have is blood. The other in-game is teamwork between the surgical center, the EMS agency, and definitive care. If the EMS and definitive care were not on board with this, this would have been a horrible outcome for this patient. All right, let's go back to Earl. So ultramental status, he's also got his belly's pretty distended, tachycardic, hypotensive. We already fixed his O2 sats by opening his airway and giving him some nasal cannula at about 8 liters. That's got him up. He's breathing about 20 times a minute, 26 times a minute. What could be going on with his belly being distended? And we know this guy's been a big drinker for the past 30 years. Yeah, he's got to bleed. Yeah, what from? His wife punching him? Wow. She's Auburn, he's Alabama. Yeah. So I'm thinking some kind of abdominal trauma. Yeah, that could do it. Other thing you can think about is you can get some ascites from these from liver disease, right? So with that portal hypertension, you get a lot of volume in those vessels there, and that fluid would shift from the vessels into the peritoneal cavity, and you'll get free fluid, and they get volume depleted, dehydrated. So this guy's going to need IV access, crystalloids, saline, LR, whatever you got. But we also know that he's got a high risk of bleeding. So this free fluid in his belly, if you're looking at it on an ultrasound, you're doing advanced practice or critical care, you got to assume that free fluid is blood to prove it otherwise, and the guy gets blood. But portal hypertension can cause some ascites. It'll give you a positive fast, just like it will in trauma. My suggestion, if you see someone who's hypotensive and tachycardic, they can't give you a good story, and they got free fluid in the abdomen, you assume it's blood until proven otherwise. So this guy can get some FFP or some blood, he gets fluids. If he's talking to you and you know he's a cirrhotic, maybe you think about doing some other things in the hospital, such as some albumin, which will kind of make those vessels retain their fluid. So cirrhotics, we get these huge bellies. Sometimes they go into the hospital, they get paracentesis, where they pull that fluid off. In addition to being uncomfortable and unattractive, what other problems can this ascites cause for people? Anybody know? Oh, I put it up there. That's not fair. So don't look. Close your eyes. Don't close your eyes. I'm joking. Yeah, so they can get dehydrated, hypovolemic, because you have this fluid that's just hanging out now outside the colon, outside the vessels in the abdominal cavity. Huge risk for that fluid to get infected with stuff that hangs out in the colon. I won't tell you what that is. We all know what that is. And these guys can get septic from that. Spontaneous bacterial peritonitis, very bad. All right. You can also have issues with breathing because you got so much fluid here, it pushes up on the diaphragm, and they have problems with their ventilation as well. The way we fix that in the hospital, once we make sure it's not blood, is we can do a quick little bedside ultrasound, find that fluid, put a small needle in there, and drain that fluid off, make them feel better. And we can look at that fluid, or the lab can, under a microscope and say, is there infection there or no infection there? We won't talk about other fun facts with ascites. Nothing really fun about ascites. Just remember that if you see free fluid, anybody here carrying ultrasound now? So I know we got some primary agencies that are teaching with it now, and a lot of flight crews are carrying it as well. All right, next case. We're getting worse and worse. Any Auburn fans here? Good, good. Do you recognize that boxer? Okay, very good, good. All right, that was funny. All right, it's a tough crowd today. So this is a young cirrhotic, just left the hospital 4 hours ago and had a big paracentesis. Remember, paracentesis is where you go in and you drain a lot of that fluid off of the abdomen. They had a large volume ascites. They put about 8 liters of fluid off their belly. A lot of fluid, right? They call EMS when they get home because they're confused, they're altered. You get some vital signs. The blood pressure about 70 over palpation, heart rate's 120. They look ashen, they look horrible. So they meet the criteria of being sick. Somebody we think may die in the next 30 minutes or so for us. So what are we going to do for this person? What do they need besides diesel fuel back to the hospital? What now? That's always your prescription. Very good. Yeah. Refill times 2, right? Yeah. Yeah. So again, like everybody else, we're going to assess and manage our oxygen. So I'm going to open the airway, slide some O2 on them. I'm getting an AccuCheck to make sure they're not just hypoglycemic. After that, at the advanced EMT or high level, we're going to start IV fluids and start slamming those in. And we got to remember, they just got 8 liters put off their belly, right? So we fixed the side effect of their liver disease, which is that fluid shift. The problem is now all the volume that they had in their vessels is going back into that belly to replace those 8 liters. So now it's like they just ran a marathon and they're 8 liters down, or probably 2 liters down. So they need rapid fluid resuscitation. They probably need a squirt or dose, push dose epi. I would not give them any neo at this point. I would do some epi or norepi on these folks. Volume resuscitation, and they need to go back to the hospital. Most folks, when you pull them on a couple of liters off of them, those guys you want to watch in the hospital 3 or 4 hours to make sure they don't have fluid shifts. A lot of times you're doing this to people that you know their process and you know that you're giving them albumin or plasma as you're pulling off this fluid and rehydrating them gently so that when they go home, we don't have this problem. The place that I work right now, we don't do a lot of large volumes because of this right here. This should be done over the course of several hours, and they should be watched, 4, 8, 12 hours afterwards as well. But you will get these calls sometimes for that. All right, next case. I think some folks think this beer is nicer than the first beer I showed, but it's really not. No, not even close. So this guy's altered. He's unresponsive. You're called because he passed out at a local restaurant. He reached down. He's got a heart rate in the 50s, very weak radial pulse, but strong carotid. He's breathing about 6 times a minute. So that's less than 10, right? So I counted more than my 15 seconds on that guy, or 6 seconds on that guy. Sats are 84%. Glucose is 116. What are we going to do for this guy? Who takes his food home? Somebody in here would. I bet you money. It's not going to be me. Yeah. So, like everybody else, we're going to pick him up, set him down. I'm probably not going to lay him flat on his back. What's going to happen if I lay him flat on his back? He's going to aspirate. So I might have some big guy sitting there, kneeling behind him. I'm going to sit him up, suction his airway, open his airway, maybe a nasal trumpet, maybe a nasal cannula, some high flow O2, right? And we start thinking about what's going on with this guy. So we could be intoxicated. Somebody could have hit him. I'm looking for life threats on this guy as well. And then I'm also thinking about, is his airway okay? That's the biggest issue for this guy, right? All right, I won't show that much. I do like vomit though, right? So we're going to assess and manage oxygen on this guy, ventilation, vascular control, neural salvage. So again, open the airway, suction that, okay? He's breathing about 6 times a minute. That's probably way too slow. So my hope is that when I open his airway and I suction him, he breathes a little bit more. Because if I have to start doing positive pressure ventilation on a guy that's probably intoxicated and just munched out at a salad bar, what's going to happen to him? Going to make it worse, right? So this is somebody that if I'm placing a airway on this guy, he really needs a definitive airway like an ET tube. Otherwise, we're going to make things worse probably. I know sometimes you can't do that, but the hope is you open his airway, nasal trumpet, oxygen, and he's breathing on his own enough that you're good with that. Okay. Look for other causes of altered mental status. So we're going to do a quick neuro exam on this guy, look him over, look for signs of trauma, make sure we're not missing something else. This is the x-ray. I know in the pre-hospital world we don't do this, but everybody talks about x-rays. This is a guy's aspirated a lot. And basically what's happened is he's inhaled his food in his vomit. And you can see he gets a bunch of food vomit in his lungs. This is not a pneumonia. You can cause a pneumonitis, an irritation of the lung. Doesn't need antibiotics. What he needs really is not to have done this, all right? But since he's done it, he probably needs to be more intubated, scoped, pull the chunks out, and then watch him until he does better. Sometimes these folks aspirate so much, even when you intubate them, you cannot oxygenate them. And the only way you fix these guys at this point is you put on something called ECMO. A lot of places aren't doing that. UAB stopped it during COVID. We just recently restarted our program, but this is literally life-saving. That way you can go in, clean the lungs out, give the lungs a few days to heal, and they don't have to actually work. And this is like a bypass machine. Aspiration is bad. That's one of the biggest risks of acute alcohol intoxication is aspiration and airway disease. All right, this may be the last case. We're getting down to the real bad alcohol now, Listerine. Anybody seen folks drink Listerine? Yeah, it'll get you going. So this is a young guy. He's in his 50s. He's been drinking since David left Van Halen. Anybody know what year that was? That was me as a kid. Yeah. All right. He got worse when he came back to the group. Says it's time. I'm quitting cold turkey. He's altered, confused. Family said he may have had a seizure. Now his heart rate's 133. Blood pressure is 225 over something. I can't tell you. So is he sick or not sick? Sick, yeah. So is he intoxicated or what's going on with this guy? He could be intoxicated a little bit, but withdrawal is the issue, right? And remember, folks that drink long term can live at a level about 4 times normal intoxicated or legal intoxicated. And when they get down to alcohol level like 200, they can start having withdrawals, right? So alcohol depresses the CNS. If you think about it as a spring, as you drink, that pushes down, decreases the heart rate and the blood pressure, decreased CNS stimulation. The body's response to long-term alcohol use is to force that spring up, but because the alcohol is there, it keeps you down. You stop drinking, and the body's response to that is increased blood pressure, increased heart rate, huge risk for cardiac dysrhythmias, for strokes, for seizures, things that kill people, right? So They start having seizures. And how do we manage these guys if they start doing this? What do we do for those folks? Benzos, right? We give them something that works on the same receptors as alcohol. So it's airway management, right? So I'm going to open the airway, passive O2, maybe nasal trumpet on this guy. I'm going to get a glucose, look for things that I can fix. At the EMT level, then you're kind of like done. You recognize, oh, I know Bubba. He's been drinking for 30 years. He quit drinking. Now he's seasoned. I'm going to check a glucose, look for signs of trauma, passive O2, slide a nasal trumpet, get a oxygen on this guy. At the advanced EMT level, you're going to start IV access, get some fluids for rehydration because these guys are probably dehydrated. And you're going to think about, am I able to give him some Versed intranasally for his seizures, right? He's probably going to be hypertensive and tachycardic. At the paramedic level, you can be thinking about the same thing, except you can think about giving him some Versed IV to kind of push that back down and make him not seize again or have a stroke. So alcohol won't make you seize as you drink it, but as you get off of it, it will. Pretty bad. Now we're going back to Budweiser. Why is that? So back to this guy. Oh, yeah. So what if he's throwing up black stuff and not bright red stuff? What do we think about now? Still probably an upper GI bleed, right? But a slow one. Something's leaked. Those varices have leaked. Or alcohol can cause gastritis and issues of that nature, kind of irritate that stomach lining, make you bleed. It sits in the gut for a little while. Your body digests it, all right? And you get that hepatic encephalopathy, confusion we talked about, all right? And as you vomit, you're vomiting up digested blood. So alcohol kind of hangs out in the stomach, tears up that lining, causes a lot of bleeding and issues that way. NSAIDs can do it as well. Ibuprofen, Motrin, Aleve, Mobic, those medicines do it. Anybody here do BC powders, Goody powders? Same things. So the way we treat this is we give block the acid production in the gut, proton pump inhibitors, right? Something to block so that acid is not made, doesn't irritate the gut. We can also give something called Carafate that kind of coats the stomach. And then old school is using like H2 blockers like Zantac or Pepsid. Works pretty good as well. Cool. So a lot of talk about alcohol today. Remember, goals of care, no matter if you're an EMT all the way up to a physician, is the ABCs that we all learned, or really assess and manage that oxygen issues, ventilation issues, vascular problems, and then try to save the brain. And just as you go from EMT to advanced, you're adding different skills. From advanced to medic, more skills, more medicines. From medic to critical care medic, and from critical care medic to ER, ICU doctors. Just doing the same things over and over again, but adding more skills, more medications, more therapies that you can do. Right? Questions, comments, or statements within reason? Nobody's even making eye contact. Who had alcohol last night? Raise your hand. All right, I was joking. You don't have to raise your hand. Okay. Yeah. Please say your name and then we'll say welcome. Okay. Yeah. Sorry. We've all been there. Chief, any questions online? Or did everybody go to sleep?
No, sir. We hadn't had any questions come across today. I think that we're all starting to think that you're trying to tell us that alcohol's bad, and we're just trying to process that.
I think that you need to make the right decision in life every day. And I'll stop there. Again, so 1 Auburn, 2 Alabama folks. Who else? Any Tennessee fans? Tennessee? Oh my gosh, we got a problem right there. Where's the law enforcement again? We need the law enforcement for the Tennessee fans.
So other than that in-clinic device, the football helmet thing, I can't remember the name of it.
It's a football helmet.
Yeah, there you go. In the pre-hospital setting, if we have actively bleeding esophageal varices, other than fluid replacement, blood administration, EXA, not really much we can do. Is that right?
Yeah, so it's recognition of the risk of having those and passing that information on. So when you get to the hospital, it's not, hey, doc, I got this guy throwing up some blood, because the doc's going to say, yeah, give me a second, I'm finishing my peanut butter sandwich, right? It's, hey, doc, I got a guy cirrhotic with variceal bleeding. That should key them, oh, those guys are sick. I should get up and go see that patient. So you should recognize the risk. If you think it's there, say it. You could be wrong, but if you're right, you're going to save a life by kind of alerting the team with that. It's going to be airway management. So those guys, you're not going to lay them flat. You're going to sit them up as high as you can, which is abnormal for some transport agencies. And you can think about good oxygenation, good suction control, IV access for fluid resuscitation, potentially TXA. And then if you have blood products, you're going to get blood products as well. Yes, sir. Yeah, so I would say if they meet the criteria for blood administration pre-hospital, they get the blood. So in reality, a lot of places, I mean, IV access you're going to have to get, and most of the time you're going to start your fluid resuscitation as you get into blood set up. But then you can step back and think, look, okay, this guy's altered, he's tachycardic, he's hypotensive, he has signs of trauma, so that meets the criteria to get blood. There's limited risk to that. Now, by the time you finish it, you get the blood ready to go. If you recycle the pressure, his pressure is normal and his heart rate is normalized, then don't hang the blood. But yes, you can do that. So even in the city of Birmingham, we're like on patient 160 or so on blood. Most of it has been trauma, but we do have some folks that have GI bleeds that we give them blood to. There's limited risk and a lot of benefit for that. Other questions, comments, Chief?
No, that does it. Thanks, Dr. Ferguson. Great lecture.
Right.
Something we all need to think about. I know GI bleeds is a pretty common call for EMS in the areas where I've worked. We're going to take a few minutes break. Everybody give you just a couple minutes to stretch your legs, and then when we come back, we'll have Dr. Gulledge will be giving us a lecture on cardiogenic shock and LVAD. So
all right, thanks, guys.
Stay tuned.
Okay, I'm Whitney. I'm one of the residents at UAB. I'm a second-year emergency medicine resident. Almost done with my second year of residency, planning to do a critical care fellowship. And today I'm talking about cardiogenic shock and LVAD complications. These, I think, are both kind of like in the weeds. I don't think there's a ton of stuff to do in the pre-hospital setting, but there are a few things that matter. Overall, these are both things that I would say kind of minimize on-scene time and try to get these people to the hospital, specifically for the cardiogenic shock and an arresting LVAD patient. But there are a few important things to do. One is, I will emphasize this throughout the lecture, is not to slam these people with fluids, okay? That's something that, like, is one of the first things we do with a hypotensive patient is give them fluids. This is one of the only scenarios when I do not want you to be slamming like 2-3 liters of fluids in them, okay? If you take away one thing from that lecture, let that be it. I don't have any financial disclosures. No one's paying me to do this. Some objectives for this talk. I don't know why they're all number 1, but we'll recognize cardiogenic shock early in the field, kind of know what it looks like in a patient, initiate the early management, the first few things you can do to help support these patients. Make correct destination decisions, both for shock and one specific cause of the shock we'll talk about, need to go to specific hospitals. And then for the LVAD, what is it? Why do patients have it? And then what do I do for an LVAD patient who is not responsive? There are different types of shock. 4 kind of classes. One is hypovolemic, whether blood loss or super dehydrated, trouble with the pipes, the blood vessels. Cardiogenic, trouble with the pump, the heart. We're not getting blood pumped out from the heart. Distributive, like septic shock, anaphylactic shock, neurogenic shock, where the blood's not getting back to the heart. And then obstructive shock, like a massive PE, something that's physically blocking blood flow. And we're talking about cardiogenic shock today. So kind of in fireman terms, this is trouble with the pump. You may have as much water as you need, but you cannot get it out because the pump itself is not working. So putting more and more water is not going to help. That's going to cause more pressure to back up and make your problem worse. In kind of fancy medical terms, it's a low cardiac output state resulting in end organ hypoperfusion, life-threatening end organ hypoperfusion. Cardiogenic shock has this really high mortality rate, like 40 to 50% mortality rate. Even in hospital, even with all the critical care supportive measures we can give them, they have a very high mortality rate. So these people are very sick. It's kind of a cycle where your primary problem is the pump failure, the heart stops squeezing, cardiac output drops, we're not perfusing any of our organs, we're backing up the fluid. And then as our fluid's backing up, we can't perfuse the heart itself. So our heart gets ischemic and then it fails worse and worse and worse. And this is a vicious cycle, which is why the mortality is so high. In the field, the kind of things that you guys will see and that we will see is, one, they're hypotensive. So their blood pressure is systolics less than 90, maps less than 65. That's kind of our state of shock, things that we'll see in the patient themselves. They're cold, they're clammy, you touch their legs, they're cool to touch. They may be altered, they're not perfusing their brain, they're confused. They are likely having pulmonary edema, trouble breathing, tachypnic, crackles in their lungs. Kind of weak delayed pulses. You won't feel strong radial or distal pulses. And then not every patient will tell you this, but they're usually oliguric, meaning they're not making a lot of urine because they're not perfusing their kidneys. There's kind of different stages of shock. I don't think these are super important for you guys to memorize, but just kind of be aware it's a spectrum. Being least severe to most severe, at risk. They're just people who have risk factors, like they may have heart failure, they've had a heart attack in the past, kind of slightly they're low blood pressure, but they're not having any signs of end organ damage. What we'll see mostly is the kind of class C or classic shock. They're hypotensive, they're altered, they're cold and clammy, and then getting worse despite our treatment. And then lastly, class E would be like they're arresting from the shock. As usual, anything pre-hospital management, we want to start with our ABCs, our airway and breathing. A lot of times, again, these patients will have pulmonary edema, kind of respiratory distress. So we usually want to avoid hypoxia, get them on some kind of supplemental oxygen. A lot of times these people will be really sick from the beginning, hypoxic, tachypnic, working hard to breathe visibly, and a lot of people, me included, when I see these people in the hospital, want to jump straight to intubation. That can be really dangerous in these patients because if you intubate them, you knock out their complete sympathetic drive, everything that they're using to kind of compensate for this shock. So these people are really high arrest patients, like peri-intubation arrest. So I always try non-invasive positive pressure ventilation, CPAP or BiPAP first, to try and stent open their alveoli and help with that pulmonary edema. There's just kind of a balance there. Anytime we give positive pressure, we're helping stent open the alveoli, but we're also increasing the intrathoracic pressure, and we can decrease preload to the heart so that we're not getting blood to the heart to pump in general. So these are not people that you want to do super, super high PEEP like you might with asthma, COPD, ARDS. I kind of like to start like PEEP 5 to 10, or if you're using CPAP, like 10/5, kind of low, moderate settings to help get that balance, but not completely tank their preload. And you want to keep their sats above like 92, 94%. And then your C, circulation. These are people we want IV access, ideally 2 large bore IVs. We want them on a cardiac monitor. We want to get an EKG because one of the important causes of shock we'll talk about is an acute MI, including a STEMI. Again, fluids. If you have a patient, their blood pressure is low, 80s over 60s, probably the first thing everybody's going to reach for is a bag of fluids if you're advanced or higher. That's okay. I just want you to be very cautious about it. I do not want aggressive fluids, multiple boluses. I would start like 250, maybe max of 500 at a time, and then reassess. Like stop the fluids, listen to their lung sounds again, check their sats again. If they're getting worse at all, no more fluids, that's it. They may still be hypotensive, but they do not need more fluids, and that can get them worse and put them faster in that spiral from earlier. Again, these are not people I want you hanging wide open, fluid boluses, pressure bagging like 2 liters. This is who you're bolusing with 2 liters of fluids. They do not need it. They're kind of already drowning, their lungs are drowning, you will make it worse, they will arrest in front of you. So it's okay, just be very, very careful. Small fluid boluses, reassess them. If they're still hypotensive in spite of your small fluid resuscitation, I would reach for a pressor next. I think norepinephrine, epi, and dopamine are all carried on the trucks, at least for the medic level and the critical care medics. They're all okay. Norepinephrine is the best one. I think a lot of people reach for epi or dopamine in cardiogenic shock patients because you think these work well on the heart, which they do. The trouble with these is that they kind of increase the demand for the heart. The heart is already trying to pump and it's failing at that, and so you're just telling it like pump harder, and it can give out. So the norepi is a little bit better because it does a little bit of effect on the heart, but also has effect on the rest of the body and helps vasoconstrict and helps raise their blood pressure without putting a lot of demand on the heart. And epi and dopamine have higher mortalities. There's risk factors as far as, like I said, increasing the oxygen demand, as well as higher risk of tachyarrhythmias, like throwing these people into VFib and VTAC. So I would reach for norepinephrine after fluids, a little bit of fluids, levo. All these people are coming to the hospital. If they are kind of peri-arrest, or if you're about to have to intubate them, microdose epi is kind of what I would reach for over the phenylephrine, microdose neo. Again, less kind of cardiac demand on the heart, but I would have the levo hanging too if they're super hypotensive after the fluids. Say we're still working on the circulation, we get them on the monitor, they're tachycardic, they're in this rhythm. Anyone know what this looks like? Kind of narrow, fast, irregular. AFib, yeah, AFib, RVR, I'd say this is probably somewhere in the 150s, 160s. And again, you may see this isolated and think I need to slow this down, I need to give this fluids, any other meds you might give if you see this in an isolated setting. In the hospital, if I have a patient in AFib RVR, I'm kind of reaching for something to rate control them, usually, yeah, like metoprolol. For cardiogenic shock patients, we do not want to do this. I would let them ride it out. A beta blocker is the last thing that they need. Remember, we're trying to support the heart. We want that inotropy. We want the squeeze. And so I would not block these people. I would not give them a ton of fluids. I would just kind of let them ride it out. I'm okay with them having a heart rate in like the 120s, 130s. They're trying to compensate and trying to pump as much blood through the rest of the body as they can. What these people definitively need is not just pressors, not just fluids, but inotropy to help the heart squeeze. The two inotropes that we use in the hospital are dobutamine and milrinone. Dobutamine is on some of the trucks for the critical care transport. I don't think there's milrinone on them. I've not seen this used pre-hospital. I would not necessarily recommend it because even though it's what they need, there are some risks of hypotension in the first place. So these patients are hypotensive to start. If we can get them fluid resuscitated, get their pressure up with a little bit of fluids, a little bit of norepinephrine, and you have a medic who feels comfortable starting dobutamine, I think that's okay. I would just be very cautious about it because they can drop their pressure kind of paroxysmally. So this is typically something that's done in the cardiac ICU, like the CVICU or the CCU. It is what they need, but there's a risk of it. So I would focus more on the fluids and the norepinephrine. I've talked a couple times, kind of given hints about some of the causes of cardiogenic shock. Any thoughts or ideas? ME, yeah, that's the most common one, acute MI. About 7 to 10% of ACS, like STEMI and STEMI, will have cardiogenic shock. It's not always immediate, but it can be if it's massive, like a STEMI. Another one would be heart failure exacerbation. You have patients who have CHF, they're drinking a lot of fluid, more than they're supposed to. They've stopped taking their Lasix. That's something that I feel like I see a lot. In the hospital, they may just have heart failure and then they have a little virus or something on top of it that's enough to push them over the edge. Or a massive PE too. You can get some obstructive shock that then causes cardiogenic shock, are the three most common ones. Other less common causes would be things like mechanical problems in the heart, like a valve rupture, mitral valve rupture, or a papillary muscle rupture. Those can happen if you've had an MI previously and you have some kind of weakening of those areas. Aortic dissection, specifically ascending, it can go into the heart itself and cause cardiogenic shock. Beta blocker overdose, calcium channel blocker overdose, and then bupropion or Wellbutrin overdose actually can cause it. These would be a little bit more rare. I don't expect you guys to get all this history with these people. And then also just blunt chest trauma can cause cardiogenic shock. What is this? LVAD STEMI. This is just a one-time snapshot. You know, you need multiple things, but this is profound ST elevation, a STEMI, that is causing shock. So say you have a patient who's 70s over 30s, cold, clammy, pulmonary edema, and you see this on your 3-lead or 12-lead, whatever you can get in the back of the truck. These are the patients that, again, all these people need to come to the hospital. These specifically, STEMI and shock, need to go somewhere not only that is capable of PCI, percutaneous coronary intervention, or a stent that you need for a STEMI. Those are places like UAB, Grandview, St. Vincent's, Huntsville Hospital, Baptist South. Those are all PCI capable hospitals. But if they have shock, hypotension from this, they may not be able to go through the stenting. Like they need some kind of support, like mechanical circulatory support that we mostly can offer at UAB. So if you have a STEMI and shock, these people need to come to UAB. They probably need to be flown there if they're pretty far away, because we can help support them while they're getting this stent with things like an Impella, a balloon pump, an LVAD, which we'll talk about. Ultimately, we have capabilities to do a heart transplant if it comes to that, because a lot of these patients, their heart is not strong enough to undergo the stent that they need to open up that vessel. Once they're in the hospital, this is kind of what we see a little bit beyond the scope, but this is a chest x-ray. We see a lot of fluffy, hazy infiltrates there. That's the pulmonary edema that we're seeing. This is an ultrasound of their heart. We see a big, huge IVC, inferior vena cava. It's not able to collapse down because all the blood is filling it up. And we see these people have a lactic acid, renal dysfunction. Their BNP, which is kind of a marker of volume status, is super, super high. And a lot of times, even if these people do not have a STEMI, their troponin will be up because they're not getting that coronary perfusion, so they're having some cardiac ischemia. So this is kind of a summary. We'll come back to cases for cardiogenic shock and LVADs later, but just cardiogenic shock, recognize it, cold, clammy, hypotensive, usually volume up, swollen legs, crackles in their lungs. Ideally, these people need CPAP or BiPAP, tiny fluid bolus, reassess, give them more if they're improving, stop if not, and then pressors, preferentially norepinephrine. We're not rate controlling these people. We're not metoprolol. We're not giving them calcium channel blockers. And then if your medic feels comfortable and their blood pressure will tolerate it, could consider initiating dobutamine, but that's typically reserved for the hospital. Questions about shock so far?
Hey, Doc, would there be any role for IV calcium in the pre-hospital setting?
I typically do not give that even in the hospital. I don't think it would hurt. Sometimes calcium being low can cause trouble with the heart, and calcium is kind of a small inotrope. I don't think it would probably make a difference one way or the other. It's kind of a can't hurt, might help situation. I think either way. Dr. Ferguson?
Yeah, I agree. There's no risk to it. So if it's a dirty presser kind of, so you can always give that a trial. Just make sure that you have that discussion with your medical director beforehand, so everybody's on the same page, so you aren't doing things they don't think are appropriate. But limited risk, potential benefit. I know some states are using calcium more than we are, so it's out there. Yeah.
Another IV medicine I did not include in this talk is Lasix or furosemide, a diuretic. That's something that these people ultimately need, but usually until they're resuscitated appropriately, their blood pressure will not tolerate it. So once they're in the hospital, once I'm able to have continuous like blood pressure monitoring on a presser or 2 pressors and on dobutamine, I'm probably slugging them with Lasix or putting them on a Lasix or a VMEX drip even when I can monitor them more closely. But I would not recommend starting that off the bat before they've been resuscitated. That's a good question.
Yeah, I'm gonna say that's great discussion on Lasix. I get that all the time about why aren't we giving Lasix in cardiogenic shock, and for flash pulmonary edema with a good blood pressure, after you're doing your positive pressure ventilation, your preload reduction with your nitro, then yes, great. Lasix is wonderful. But if they're hypotensive, I would not be pushing Lasix on those folks. So great point. Thank you for covering that.
Yeah. Okay, so that's cardiogenic shock for now. Next is an LVAD and complications of an LVAD. LVADs are scary to me, someone 2 years into residency who sees them like not infrequently. Has anyone seen an LVAD patient? Okay, a few, yeah. LVAD stands for left ventricular assistant device. It is usually given in patients who have very severe end-stage heart failure. It previously was a bridge to other things, like a bridge to a heart transplant. But more and more often it's becoming destination therapy, meaning some patients may have such advanced heart failure, such severe comorbidities, they're not ever going to be a transplant candidate. But the LVAD itself can improve kind of their life. It can alleviate their symptoms of super bad exertional dyspnea, exertional chest pain, can let them walk around. So we're seeing more and more patients with LVADs as their end stage. They're not getting anything else. They're living with an LVAD. There's about 2,000 patients nationally who get an LVAD every year. Here in Alabama, they're mostly done at UAB. This picture is from Grey's Anatomy, if anyone's seen that. This is Izzy, one of the residents, and Denny Duquette, who has an LVAD as a bridge to therapy. What I would not recommend doing for these patients is ever cutting the wire or disconnecting anything from the LVAD, which she does in this show. Kind of simplifying the LVAD. Basically, it's a pump. So there's the assist device that comes from the left ventricle, that takes the blood from the left ventricle and the rest of the body, puts it to the aorta and pumps it. And then you have a drive line connecting the pump, comes out through the stomach, connects to a controller, and then you have batteries, usually on either side. And that's kind of all it is. There's a lot of different parts inside the pump, but overall, this is what it is. And the patients typically will always have backup batteries and a backup controller on their person or in a bag at all times. They should have a person, whether like their family member, also with them who is trained on this, how to change the batteries or the controller if needed. And I would bring those things to the hospital with you if you can. Bring all their equipment with them. Patients with an LVAD don't have a pulse, typically. We have systolic, diastolic, lub-dub that's causing our pulse. LVAD and BiVAD or biventricular devices are continuous flow. So it's not a lub-dub. It's just a continuous thing. So you will not feel a pulse on these people. That's normal. They can be awake, talking to you, walking around, and they do not have a pulse. They just have like a systolic blood pressure. So you can't feel a pulse. You won't typically get a manual. And to assess perfusion or blood pressure on these people, you have to do a Doppler. Ideally, these people should still have a systolic around 70 to 90 is what you should hear with the Doppler. But whenever we're assessing a patient with an LVAD, if they're unresponsive, they won't have a pulse. If they're responsive, they will never have a pulse. So we can't use the lack of a pulse as an indicator that their LVAD is not working okay. Kind of my way to simplify this, again, LVADs are scary to me. I get alarmed when I see one. I don't feel super comfortable with them, but I know that there's always help. One thing that I always do, and I would recommend you guys do in the pre-hospital setting, is it's called the LVAD coordinator. There's a 24/7 UAB LVAD coordinator. The patient should have the number like on their pack. They will be registered with the LVAD people, and any alarms on the controllers, anything that's going wrong, these are the experts, and these are the ones who will help guide our management pre-hospital, in the hospital, once they're admitted to the hospital. So I'd always call these people. With any other patient, I'm looking at them. Do they look okay? Are they mentating? Are they talking to me? Do they seem alert and oriented? I'm listening. I won't hear the lub-dub heartbeat, but I should hear kind of a whir, a mechanical whir, like a hum, and that means the LVAD's working. Looking at their battery, is it charged? There's a button on all the batteries that you can assess the charge. I'm getting a blood pressure, a manual Doppler. I'm looking at the controller. Is it giving any loud alarms, like a low flow alarm, a high power alarm, things that we'll talk about in a little bit. I'm looking at their drive line. Again, that's the wire that connects from the pump to the outside of their body. Does it have anything red, purulent around it? Does it look infected? Is the drive line disconnected? Is it all intact? And then these people too will need an EKG in the pre-hospital setting, ultrasound if you have it, echo, see if they have a big thrombus or any obvious valve abnormalities that you can see. If you don't have an ultrasound, that's okay. They'll do it in the hospital. There are a lot of things that can go wrong with an LVAD. The biggest thing, I think, and the most important that I wanted to talk about is a cardiac arrest with an LVAD. There's a couple smaller things like driveline infection, thrombus, bleeding, things that we'll talk about in a little bit, but this is the one that I want you guys to be able to know what to do, how to recognize an arrest, and things that you should start to look at that are a little bit different from a patient who's arresting that does not have an LVAD, okay? So if you go to a call, it's a patient, and they have an LVAD, they're not responsive, they're not alert, they're not talking to you, you feel they don't have a pulse, but you know that's normal, and you listen, you don't hear a hum, they're cold, they're not perfusing, they do not seem to be okay. Normally, first thing we would do immediately is get on the chest. That's what we teach everybody for CPR. That's the one thing that we can do that changes the mortality. That is still true, but for these patients, ideally we want to restart the LVAD because the LVAD is what's pumping their heart. Compressions, we're pumping the heart for them. We're trying to get the heart to restart on its own. These people, their heart's never going to restart on its own because it's not beating on its own. It's using the LVAD for all of its support. So we don't want to totally forget about chest compressions, but we want to try and restart the LVAD first. The guidelines say usually like 2 to 3 minutes is kind of the delay that we can have to look at everything, look at the drive line, look at the controller, look at the batteries, try and troubleshoot those things, try and reconnect it and get it started before immediately jumping to chest compressions. If you can't do those things after about 2 minutes is when I would still start doing CPR. Just like normal, your regular 110, 120 compressions a minute. You can put the Lucas on these people. If we're doing compressions, try to do it like a little bit more to the right or left of midline, like not right over the controller that you'll feel. But ideally, again, we want to restart the device if we can. So you look at a patient, you're looking for signs of life. Again, we're not looking for a pulse, but hey, can you hear me? Are you talking to me? Are they talking? Are they breathing? Do they have a capillary refill? Is their controller alarming? Do they have that LVAD hum that we're listening for? If not, we assume that their LVAD is not working. We can go ahead and ventilate them, and then we're trying to troubleshoot. We're looking for all of these things that we may be able to fix to restart the LVAD and then restart their heart. Here's a small little diagram of it again. LVAD, the pump, driveline, controller, and batteries. We want to expose everything, take off their shirt, look for where everything is. Sometimes they're on a little backpack. We want to look at all the different pieces of it. Check the battery. Is it a dead battery? That could be a really easy thing. Get their spare battery, hook it back. Attach it to a spare controller. Try and disconnect the drive line from the old controller. If it's not working, connect it to their spare controller. If none of these things are working, another problem that they may have is a cable fracture, meaning that this is disconnected somewhere inside. If that is the case, again, within this 2-minute mark, you can kind of gently manipulate the drive line, move it around, and see if it restarts that hum. If it does, I would tape it, secure it in place wherever it is working, and kind of leave it alone. If at any time this patient, this unresponsive or unstable patient, if you get them on the monitor and they have a shockable rhythm, like VFib or VTAC here, you can shock them. You don't have to disconnect anything on the LVAD to shock them. You don't need to turn it off to shock them, just like a Lucas. You can shock through it. If they're mentating fine, I would not sedate them and defibrillate them, but if they're unresponsive, hypotensive, any sign that they're not perfusing, it's okay to shock them. So just to summarize, if they're unresponsive, we're not going to feel a pulse. We're looking instead for signs of life, signs of perfusion, listening for a hum, trying to restart the LVAD, exposing everything, and if not, we're still starting compressions. Again, all of these people we're transporting. I know it's a stay and play thing. If we can stay on the scene and resuscitate them, these people ultimately need the hospital. There, again, are more minor emergencies, other problems that are not just a totally unresponsive, not working patient. Little mnemonic for those I found was death, D being driveline complications, and device failure, which we just talked about device failure. E, embolism. These people are anticoagulated, but they have something metal, something mechanical in their heart that's not supposed to be there, so they can form clots on that. Arrhythmia, we talked a little bit about VT and VFib in an unresponsive patient. We also might see these arrhythmias in a responsive patient. Thrombus, they may have just a clot on the device that hasn't embolized anywhere. And then last, hemorrhage, kind of balancing the bleeding and the clotting risk. All these people are anticoagulated. The most common thing we'll see is like a GI bleed. As far as embolism, thrombus, there's not a ton that we'll do in the pre-hospital setting for these people other than get them to the hospital. So I just have a couple slides on like the driveline, the arrhythmia, and the hemorrhages. This is what a driveline looks like in a patient. Again, it's a wire that's coming out of their belly. It's infected. It might have some purulent drainage, some pus coming out. It might be red, tender, swollen, warm to touch. These people ultimately need antibiotics, imaging, cardiovascular surgery consultation. Really nothing to do in the pre-hospital setting. Not a lot for me to do in the emergency room. I had a patient like this one time that I physically like touched around it to see if I could express any pus, and the coordinator was in the room and she was like, please don't touch it, please don't touch it. So just leave it alone. As long as it's working, get them to the hospital. If they're responsive and they have an arrhythmia like VT or VFib, I would not shock them as long as they're perfusing fine, mentating well, have a good systolic. They should still be on the pads. We can give them whatever medicine per our protocol, amiodarone, lidocaine, and they ultimately need to come to the hospital too. They might have some underlying electrolyte abnormality, some underlying ischemia that's causing the dysrhythmia. But as long as they're stable, we don't need to shock them. If they're unstable and not perfusing, they can be shocked, just like we talked about. And then hemorrhage, we see GI bleeds a lot in normal Alabama patients. These people typically are on warfarin or Coumadin, so that they don't form a clot or a thrombus. And they'll usually have like lower GI bleeding, black tarry stools, belly pain, sometimes upper GI coughing up blood. If these people are hypotensive, we could give them a little bit of blood if we have it. Ultimately, these people need to come to the hospital too. So a big theme with LVAD patients is get them to the hospital. Some other alarms that you might see on a controller. Sometimes it will blare, make noises, and it will usually display these on the controller itself, is a low flow alarm, meaning that the device is seeing kind of lower volumes than it needs to. This could most commonly be because the patient is hypotensive or hypovolemic. These are people that I too would give a little fluid bolus, 250, 500 cc's, can do a passive leg raise, and then get another Doppler map, see if that is better, and then give them some more fluids. If it's a high power alarm, that specifically is concerning for a thrombus. Not a ton to do other than get them to the hospital. A controller fault alarm, something's wrong with the controller, exchange it for their spare, get them to the hospital. Low battery, replace the battery with their spare batteries they should have with them, bring all their stuff, take them to the hospital. And I might say pump stoppage, meaning the pump is not working. And that's the case, again, we would expect not to hear a hum. They're probably about to arrest if they're not already. We want to check all the things, reconnect as much as we can, initiate CPR if possible. And all of these patients are going to the hospital. LVAD questions. And then we've got a couple of cases.
Yeah, so I guess I'm kind of confused about the production of an ECG rhythm. So do most of these patients have a heart that is beating and the LVAD's just assisting? And does that action not really distort the ECG? I mean, do you get a normal ECG? For example, can you evaluate a LVAD patient for ST elevation?
You still can, yeah. They might have some artifact on the EKG. Just because they don't have a true beat doesn't mean they don't have electrical activity. And you may not be able to feel a pulse, but usually the LVAD is kind of doing the entire work of the heart. It's not just supporting it. There's some other mechanical supportive devices that we use in the hospital. Specifically, what is coming to my mind is what's called a balloon pump, and that is something that the heart's beating on its own. With every beat of the heart, the pump inflates and deflates and helps kind of assist blood flow. This one is working all the time. It's like an artificial motor that is making the heart run.
I'm just wondering if they could be in like a V-fib and be unresponsive for some other reason, like an opiate overdose, and their blood flow actually be normal to what their baseline is. And that's true, isn't it?
Yeah. So sometimes
it's really complicated.
Yeah, super complicated. These are complicated patients at baseline because they have a drive shaft in their heart, right? So they're sick as dirt at baseline. So you'll see some of them have weird rhythms. Some of them you do a 12 lead on them, and there's so much interference that it just like is too much artifact. And then sometimes there'll be a dysrhythmia talking to you. And then sometimes the EKG is normal. So it depends on the patient, depends on what's going on with them, and sometimes that'll change. So they're just complicated patients. I mean, they have basically an artificial heart, right? A pump driving their flow. So they're sick as dirt at baseline.
So would you approach, I mean, I don't know how common it is, but if you knew your patient had an LVAD and you saw a Brady rhythm on your monitor, like in the 30s, you necessarily treat it?
I would kind of try to let the patient's clinical condition guide the management, because they may, on your monitor, have a rate in the 30s or the 180s, but as long as they are looking okay, I would kind of let it ride. I would not necessarily treat it. If they're looking ill, sick, diaphoretic, cold, clammy, if you're getting a low pressure, then I would kind of believe it and treat that like normal, but otherwise I would let it ride.
Yes, I don't think we're going to be able to get a pressure on these people in the pre-hospital setting.
Sometimes you can, sometimes you can't. So it goes back to your assessment. You got to look, are they alert? Do they look well? Or are they diaphoretic and look like dirt, right? So if they look well, it's going to be smile, nod, thank you for choosing our health system. We'll move you to the hospital right now, right? If they're ill, then you got to decide what do you do with that. My suggestion is if their heart rate was 30 and they're ill appearing, diaphoretic, they say they have symptoms, then I'm probably going to put them on the pads. I'm going to look at that drive box, see if there's an alarm going, and see which one it is. All right, somebody starting IV access to start a little bit of fluids, not slamming them, but just for IV access at the medic level. And then somebody should be on that phone calling UAB, where we have the LVAD folks, and we have docs like her answering the phone, right? And say, hey, doc, I got this 48-year-old guy with a heart rate 2. The low flow alarm is flashing red. His heart rate's 20. He's confused. What do you want me to do? Right? And then we're going to say, oh, yeah, well, sure. Give him 500 cc's of fluid. Give him one of atropine. Hang some norepi. Or we'll say do nothing. Maybe you say, oh, look, he's in VTAC, but he's talking to me and smoking a cigarette. What do I do? Put a cigarette out. Put him on some oxygen. That makes sense? And nobody smiles on this side of the room whatsoever. This makes me uncomfortable.
Thanks. Sorry for the interruption.
No, that's a good question. Again, these patients are tough. I, with all my hospital resources, am like, I don't want to see this patient. If there's an LVAD patient, I'm like looking the other way, which is why I'm trying to make it just like as simple as possible. Yeah, that's a great question. I don't know that I have an exact number, and I think it depends on if it is their destination therapy or if it's a bridge to transplant. And of course, LVADs are, in conjunction with all of the medical management that we can give these people, like aspirin, beta blockers, ACE inhibitors, ARBs, like all the medical management. But I would say, like, with no complications, LVAD patients can last 2 to 3 years. Like it's not just a months, weeks thing anymore. It used to be, but it's getting like people are living with LVADs, walking around theme parks with LVADs, kind of living their regular life with an LVAD. It's crazy medical technology.
Yeah, they're more common. It used to be you'd see these folks and they would go home and they'd have to have somebody assigned to them, a caregiver that knew the LVAD could help. Now they don't have that. And we see them all the time in the ER now. And I'm like you, they make me uncomfortable because they got this drive shaft going into their heart. But you see a lot of these folks I think key things from those folks is first recognize, oh, you have a drive shaft into your chest, right? Don't pull that wire out. Don't cut the box. Don't cut the cable, things of that nature. And a lot of times they are probably the best person to get the history and tell you what to do if they're talking to you. Because a lot of times they come in, they tell me, oh, look, my first battery was dead. I put the second one in. Now it's saying low flow. I probably got a clot. I'm like, oh, great. So I call the LVAD coordinator. Hey, their first battery was dead. They replaced it. Now they got low flow. They probably got a clot. And I got that information from the patient who knows what's going on. But they are sick as dirt at baseline, even though they're at home doing things. The high risk, if they fall and they're on these blood thinners, they could have head injuries, they can have GI bleeds, they can have COPD exacerbations. The thing that caused their heart to fail the first time is probably still going on, which is probably diabetes or something else. So they're just super sick. My suggestion also is this is kind of funny, that if you have an LVAD patient, you show up and their complaint was like fall from standing or weakness or even a lift assist, and you get there and they're talking to you and you feel for a pulse and they don't have a pulse, don't start chest compressions as they're talking to you, right? Because they don't seem to appreciate that for some reason. So it's just a weird experience, right? So
It is.
So just a quick NIH search said 75% survival currently after 2 years. So at the 2 year mark, 75% survival.
75, is that what you
Yeah,
said?
and they're saying commonly surviving 10 to 13 years or longer.
Yeah, I mean, look at Dick Cheney, right? Now, I know he had clout, but same thing. So it's crazy. Yeah. So great topics. I like it. I'm not a LVADs make me nervous too. I'm always on the phone with the coordinator or the cardiac guys because it just makes me uncomfortable. If all the lights are green on their pump, I like that. Because I know they can't do anything for them because that's working well. If one of those lights is flashing red, then you got to start doing some more thinking and getting those guys involved. A couple of good points on the cardiogenic shock she talked about. Most important thing is to recognize that patient is sick. With cardiogenic shock, you get cardiac symptoms and some pulmonary symptoms sometimes. So recognizing that and early intervention, even at the EMT level, which is recognize, oh, this guy is in frothy sputum, sounds like dirt, hypoxic, low blood pressure. Set them up, CPAP, BiPAP, oxygen, and get ALS care on the way. Super important. Remember history, when you're asking patients about their history, what kind of health problems they have, the purpose of that is not to check a box on ESO or whatever documentation. The purpose is for you, the healthcare provider, to risk stratify your patient. Oh, Mr. Smith has diabetes, he's on insulin, I should get a glucose, kind of guides your care. Mr. Smith has diabetes, is on glucose, and now has chest pain. I probably will get an EKG on him no matter what, but because he's on insulin, is a diabetic, he's higher risk for having heart problems. Maybe now I put that O2 on as my buddy grabs that 12 lead to run a 12 lead on him, and it kind of guides your care, right? So good points that we covered. What else do I think about? So we talked about use of the inotropes. That was a great coverage on that. And all the flight guys out there got excited when we talked about that because they carry norepi, dobutamine, dopamine. Not many folks carry milrinone, but dobutamine is out there. Norepi is probably the better pressor for most things except symptomatic bradycardia. Symptomatic bradycardia, dopamine is a great freaking drug. And then it kind of ends, right? Who carries dopamine? Anybody carry dopamine anymore? So a few folks. So I love it for post-cardiac arrest. The patient that was, VFib, VTAC, we're working them, give them a slug of amio, and then I shock them, and they come back. And most of the time they come back there in that junctional rhythm rates of like 50 or so, right? Because you just took this dude who probably had a STEMI, right? And went VFibbed, and I gave him a slug of amio, and I shocked him. So I fixed the problem with the shock, but I just gave him 300 amio. So now he's going to be slow. Dopamine's a great post-arrest drug for that. And that's about the end of it for dopamine, in my opinion. Norepi's great. Push dose epi's pretty good. The dobutamine, my suggestion on dobutamine is if you have, as an ALS provider or critical care provider, if you have someone that's an AFib RVR, like she said, sometimes you just kind of watch that rate, you treat the underlying problem, and you let it ride a little while. Because if you got something driving that AFib RVR and you give them a beta blocker or a calcium channel blocker, you can actually make them worse and drop the pressure. So I usually have that dobutamine available for those guys that are soft blood pressures, AFib RVR, and I'm thinking, I got to fix this with a medicine or electricity. If I ever convert AFib RVR, I'm popping the modal, and the next drug I grab is dobutamine. I'm getting that ready, the modal. Thank you for laughing. I know. The modal's for me. The dobutamine is there so that if I drop their rate, and their rate was to keep their cardiac output up, right? Now I got a way to salvage them and save them from that slowing the rate with that dobutamine. So these vasoactive drugs get very confusing. You don't use them a lot, but you got to know what to do if you're going to intervene on some of these AFib RVR patients. So sorry, I'm talking way too fast. I had a Coke. Chief, what else you got?
Well, just on, Dr. Caldwell, you got a comment?
This may have already been said, but
you go.
every LVAD person has somebody that is trained on how to work the LVAD, how to troubleshoot the LVAD. And so if your LVAD patient is unresponsive and cannot help you, there should be somebody with them or that can help you manage that. It's just good to know that. That's all.
Yeah, the family's educated as well. They did change it though, so they're not required to have somebody all the time. Yeah, so it does change it up a little bit, but in theory, they should have somebody. And those guys are pretty health literate because they're alive because they got that thing stuck in their freaking chest, you know? So what other questions you got back there, Chief?
So when we're talking about cardiogenic shock and treating it with pharmaceuticals, I realize the point is probably given inotrope, something that increases the squeeze of the ventricles, right? But a lot of this stuff we're given is really vasoconstrictors. So are there any other vasoconstrictors at our disposal that we haven't mentioned? Or
I mean, the only thing you can carry is epi for push dose or epi infusion. You know, some of the flight guys carry Neo, but I think Norepi is probably the best drug, like you said. And state says that ground ALS can carry that now, but it's titratable, and you should be using that on a pump. That should not be an eyeball on these patients, like we talk about for like dopamine sometimes post arrest bradycardia. It should be on a pump.
so back to the LVAD. I'm fascinated with the idea of getting an LVAD patient who's in cardiac arrest. I don't think I would recognize that they had an LVAD immediately. I
Right.
just don't.
Yeah.
Well,
that's
I think there's a possibility I would not recognize that
Right.
they have an LVAD immediately. So,
yeah.
I mean,
So when you have someone in cardiac arrest, in theory, you should have opened the airway, right? You should have cut their shirt open so you can look at the chest, doing chest compression, put pads on. At that point, you should be able to recognize they got this big wire going into one side of their body, right? Usually the left side, going to the heart. So you should see that in theory. Yeah. I'm surprised nobody's asked a question about, and did you talk about chest compressions with LVADs?
Just briefly, it's not, chest compressions are not going to hurt. It might damage the equipment, but if this patient is dead, they're dead. And that's like, there's nothing that you can do that will make them more dead. Anything they do might help, might bring them back.
Yeah.
I'd be surprised.
Hold my beer.
And that's what I say, you know, to myself in the hospital, to my interns too, especially like running a code. If they don't get the patient back, there's a lot of feelings of like failure, but that I did something wrong. But it's not that you did anything wrong. They're dead, and all you can do is try. You probably still aren't going to bring them back, but you can try. And so these patients, like, it's okay to do compressions. You might damage the LVAD. It's not working anyway. And you probably will not get these people back just with compressions because, again, their heart is not beating on its own just because of whatever end-stage heart failure they have that caused them to get the LVAD. What they need is to get the LVAD restarted. And that's why compressions may not be the definitive treatment. It's trying if the driveline is disconnected, if the battery's dead. That is the thing that's going to bring these patients back, and not just the compressions. But if you have two people, you know, you have one person on the chest, the other person trying to troubleshoot and reconnect everything, reconnect the spare battery, connect the spare controller. Yeah, it's a great question. If everyone heard online, is there anything different you should do with pad placement if you're going to shock them? No, there's not. You can do the typical AP or anterior lateral position, and will work fine. You can do the dual sequential too if you're fancy, if you've shocked them a million times, but nothing specific different. Great question. Yeah. That's a great question too. Does not matter. It can do either arm.
Yeah. And for me, I'm telling you that I'm if they're talking to me, I think they got enough perfusion that I'm not going to Doppler blood pressure. I'm going to start moving them toward definitive care and that LVAD coordinator. Now, sometimes that's an hour and a half drive, and I get it. You got time. So yeah, the mental status. Oh, even better. Yeah. Okay. Gotcha. Yeah.
I think too, there's probably for some of these cases that might be bizarre, like we have a LVAD patient who's unresponsive for dyspneic or even apneic, but it's not a cardiac reason, which can happen, right? They
Yeah.
have all the same medical problems plus some, the normal patient population.
Yeah.
I think end-tidal CO2 would be a great way to determine too if we're getting adequate perfusion.
Yeah. So years and years ago, when they started doing, there was people would not call or stop resuscitation on LVADs in cardiac arrest until they got to the Mecca, said they were dead. But you can tell that some folks are not alive, without driving 3 hours to get to the LVAD center sometimes.
Yeah, I think that's kind of what I'm saying is that, I mean, if their end-tidal's under 10 and
Yeah.
you've been trying to resuscitate them, it's still falling.
Yeah. It's probably over. Yeah. Unfortunately. Yeah. And like she said, these people are sick as dirt at baseline. So cool.
Yeah, but you're totally right. These people can have all of the regular medical problems. Anybody else, like hypoglycemia or opioid overdose or anything else that may be the cause of their unresponsiveness. This specifically is just saying, like, if they are not responsive, try to restart the LVAD. Great questions. Other questions? Otherwise, we'll go through these cases quick and take more at the end. Okay.
Go.
Oh, yeah, in the back. I don't know. I would say ideally go where they received it. Do you guys know, Dr. Craig? Great question. Okay, here's our first case. We only have two. So this one, you're called for a 56-year-old guy. He's coming in with exertional shortness of breath for 1 day. Just gets really winded when he walks. Kind of looking at him, he looks pretty unwell. He's diaphoretic, kind of clammy, labored breathing, tachypnic, using his belly muscles to breathe. He's got crackles everywhere that you listen. He's got really bad lower extremity edema. His legs are swollen. His legs are cold. His cap refill is delayed. He's with it enough to give you a little bit of a medical history. He's got coronary artery disease. He had a stent previously. High blood pressure, high cholesterol, diabetes, smokes every day, all of your regular comorbidities. And you get a set of vitals on him. Okay, there we go. You get a set of vitals on him, and his blood pressure is low, 90/50. He's a little tachycardic, 117s, breathing about 30 times a minute, satting 85% on room air. Sick or not sick? Sick, I agree. So airway, breathing, circulation, tachypnic, hypoxemic. Again, a lot of us might immediately want to intubate this person, and I am right there with you. I want to too, but they will probably die, and they might already, even with all these things. Again, really high mortality. When I see these patients, they're going to an ICU, MICU or cardiac ICU, if I can get them there. This, like, out of all the patients, aside from traumas that I have in the ED, who have died, who have been like really bad cases, it is cardiogenic shock people. These people are sick. You might have to intubate them anyway, but try to get them on the non-invasive BiPAP or CPAP first, sit them up, kind of open up their lung fields if they can tolerate it. If you do have to intubate, I would try to reach for something that will not tank their blood pressure. Like, I'm not giving these people propofol. I'm usually giving ketamine, maybe etomidate. I would use rock instead of sucks. Sometimes these people can be really hypo or hyper K. Vent settings, not super important, but like if you're critical care, air, kind of a low tidal volume, we want to minimize the barotrauma. Again, pretty low, moderate PEEP. We don't want to increase their intrathoracic pressure too much. Little fluid bolus, and again, these people are high crump risk, so I have pressors hanging or at least push dose epi if I'm intubating them. And then their circulation, hypotensive, super tachycardic. Are we giving these people 2 liters of fluids? Hopefully not. Tiny, tiny little bit, 250, 500 cc's, and we're reassessing. We're listening again. We're looking at them again. It's okay. You can give them some fluids, but please do not just slam them. And it's not just pre-hospital. There's like hospital patients, emergency room patients that they are an AFib RVR or they are hypotensive and they get 2 liters of fluids, they get metoprolol, and then they're in florid cardiogenic shock. They're doing horribly. So it's natural to want to give these people fluids. Just try to remember like, oh, this person might not be volume down. They might have a pump problem. They might not need fluids, and I could kill them if I'm just slamming them with fluids. That's your cardiogenic shock. Second, you're dispatched to a 62-year-old. He has an LVAD. He's kind of dizzy. He almost passed out. He's awake, but he's lethargic. He's cool, pale, not really able to talk to you. Doesn't seem to be in respiratory distress, breathing fine. We don't have a pulse. Normal, that's okay. We listen to him. We do hear that hum, that kind of mechanical whir of his LVAD. His LVAD's working. And we are somehow able to get a Doppler on him, and his MAP is 58, so pretty low. On our LVAD assessment, we're kind of exposing his driveline, his controllers, everything. There's no big alarms. Well, there might be an alarm actually, but it's intact. It does not seem to be disconnected, does not look super infected. We have a low flow alarm. So what might you want to try for a low flow alarm? Yeah, there might be a blood clot. Definitely this person needs to come to the hospital. Might be a blood clot, might be a little hypovolemic. What I would try for this patient probably. Anyway, so like, is this patient to you, are they responsive, unresponsive? Is their LVAD working? Are we starting chest compressions on this person? No, because their LVAD's working. They don't need compressions. Anyway, okay, we finally here's the rest of their vitals. We don't have a pulse on them. A little hypotensive, breathing fine, satting 94. They're not terrible. So we'll place them on the monitor. We'll get IV access. With that low flow alarm, we might try to get a little bit of IV fluid. Passive leg raise, try and raise that flow. Let's just edit that out. Okay, we get them on the monitor, and this is what we see. Again, we're not feeling a pulse, but whenever we have them on the monitor, we're still sensing that electrical activity. We see heart rate in the 180s. What rhythm is this? VTAC, yeah. And their pressures in the 70s, MAP 50s. They're not super responsive. This is somebody that I would say we can shock. Do we need to disconnect LVAD? Okay, we don't want to. We want to shock them just like normal. It's unstable. We can shock them with our regular 100, 200 joules. You can do up to 360. There's no problem. It's not going to fry them with the LVAD. We can shock through the LVAD. Okay, these are just a couple of like review slides. Again, first thing is being able to recognize the shock patients. What are they going to look like? They're cold, they're clammy, they're altered, they're not perfusing, their blood pressure is low. Heart's not squeezing, and their lungs are full of fluid. So if you can see that and think this person is probably in some kind of shock, maybe cardiogenic, they're sick, I need to get them to the hospital. I don't want to slam them with fluids. LVAD, briefly, artificial motor, continuous flow, will not have a pulse. If it's not working, try to restart it. Try to restart it 2-3 minutes. If not, you can do compressions. You can get on their chest, bring their equipment, call the LVAD coordinator. Another review slide, cardiogenic shock, non-invasive ventilation, avoid intubating if we can, give them a try for CPAP, BiPAP, little fluid bolus, and then ideally norepi for your pressor. LVAD patients, we're not assessing a pulse, we're trying to assess their perfusion, a Doppler if we have it, if not like cap refill, signs of perfusion, they're talking to us, they're answering questions fine. Try to restart this before CPR because that's the problem. That's what's going to help is restarting that, and then call the LVAD coordinator early. Other questions? Shock or LVADs?
It was a lot. Very good.
Thank
Got
you.
a couple of questions came in from online. One was any restrictions on bleeding control interventions with LVAD patients?
Restrictions on bleeding control interventions?
Yeah, I think they might be hinting there. Is TXA okay?
TXA, I think is okay. Again, if they're bleeding and they're sick, you can't really waste a ton of thought on, am I going to reverse their anticoagulation? Am I going to make them form a clot or a thrombus? If the life-threatening problem they're having is bleeding, I think it's okay to give blood. It's okay to give TXA. If we're in the hospital, we may be reversing their warfarin with like vitamin K or PCC, something like that. But I would say, I don't know all the protocols off the top of my head, Dr. Ferg, but
I think if
it's
this is
fine.
a trauma patient and they're critically ill from trauma, they're anticoagulated, then TXA is reasonable. I would not be using this for probably GI bleeds or other kind of sketchy things, but a trauma patient that has an LVAD, they're anticoagulated, yeah, TXA in blood. What else are you going to do?
I think it's a reasonable question. There.
No, it is a reasonable question.
The other one is kind of a story. I'll try to summarize it for you. See if I can summarize this epistle. Essentially, a volunteer fire department gets an LVAD patient. They call a number to Cincinnati, don't get an answer. Ended up calling New Orleans for LVAD support. And they're asking, so we can call UAB or USA, and how about give us the number? My understanding is those numbers should be on the device for support. Is that correct?
It should be, yeah. You should be able to get in touch with a coordinator all the time. That's kind of a smaller percentage of patients, I would say, who are traveling through. Maybe they got their LVAD in Pennsylvania or somewhere else. But we do have a UAB LVAD coordinator, like on call 24/7, that we should be able to get that number.
Yeah, I would. So if you have time to make that call, you can call the UAB switchboard. It should be 205-934-3411, I believe. It's a switchboard, and they can connect you to that LVAD coordinator if you have time. If this is a real-time emergent, I got to have somebody tell me what to do right this second, that's a med control call to your med control physician, to your local place, or to the UAB ER number, which all agents should have access to as well.
Very good. Great lecture. Thank you, Dr. Gulledge. Thanks, Dr. Ferguson. As always, Dr. Ferguson, where are we going to be next time?
UAB Midwest with McAdory Fire, the second Wednesday of April, and then the last Wednesday, we're at Albertsville. I think we're off cycle for that because of FDIC, but I can't remember. But April 8th is the next one. I think the 25th is the next one. Don't forget, CCTMC is at Orange Beach. It's close. Good conference, national conference. And then FDIC is next month too. So
give us some feedback. As always, thank you for joining, and we'll see you next time.